Good afternoon, ladies and gentlemen, and thank you so much for the opportunity to present our guidelines on stroke in women, management of menopause, pregnancy, and postpartum. And this was our model working group, a large international group, and it was a pleasure to work with them and also the reviewers. And these are the disclosures, busy slide of busy people, but nothing in regard to the topic of the guidelines. To start, this is the background. You heard a lot now this afternoon about the hormone replacement therapy. There is an increased vulnerability for stroke in women during menopause, as Theodore also pointed out, and there are conflicting results regarding stroke risk. And actual guidelines of the last years, they are lacking. And the other big topic of our guidelines is the stroke in pregnancy, postpartum menstruation. Regarding stroke in pregnancy, you've also heard this afternoon that it increases. It's widely ranging estimates from 1.5 to 98 at 100,000 deliveries, and the rate is around 30. Guidelines regarding the acute management with IVT and mechanical thrombectomy are lacking, mostly because pregnant women are excluded from randomized controlled trials. We developed this guidelines according to the standard operating procedure, and it's the GRADE approach, grading of recommendations, assessment, development, and evaluation. And we formulated 2 PICO questions, which are our main topics: the stroke in pregnancy and the menopause. Patient intervention comparison outcome PICO question, we will hear that in the next slides too. We identified the main outcomes and rate their relative importance, and we identified 15 critical outcomes. We did the systematic literature review for each of these 2 PICO questions with the 8 subheadings, and we assessed the risk of bias in each trial. And then we summarized the relevant evidence in GRADE evidence profiles. We did the meta-analysis, and then we graded the quality of evidence in very low, low, and high, and the grade of strength in weak and strong. And if it was not, the evidence available was not enough, we added an expert consensus statement, and we did the Delphi votes. And at last, we tried to reach a consensus among the model working group members regarding the guideline document. So these are our critical outcomes. Just remember, we have 2 main questions: the hormonal replacement therapy and the IVT-MT in pregnancy, postpartum menstruation. And for the hormonal replacement therapy, it was stroke all, ischemic, haemorrhagic, and mortality. Critical is the one that received 7 to 9 points, and the one with the 9 points are the most critical of the critical outcomes. For the IVT-MT in pregnancy is the modified ranking score at 90 days, and the mortality, the hemorrhage, the major bleeding, intracerebral hemorrhage, asymptomatic cerebral hemorrhage, intracranial bleeding, and all major gastrointestinal bleedings. And what is also important, the health of the baby, because it was not included in registries. Often they did not include the health of the baby and the type of delivery. For the hormonal replacement therapy, it was our first PICO. We had the question, and it's the PICO question: patient's intervention, comparison, and outcome. In postmenopausal women, does hormonal replacement therapy compared to non-prior hormonal replacement therapy reduce the risk of ischemic stroke in primary prevention? And in postmenopausal women, we suggest against the use of hormonal replacement therapy to reduce the risk of ischemic stroke, with a very low quality of evidence and a weak against intervention. Let me give you some additional information for this recommendation. This is the GRADE evidence table for ischemic stroke. We included 6 studies, and I give you a short overview to the time, but 6 studies were included, and 3 were on hormone replacement therapy and 3 on receptor modulator. And they all had, if they were combined, a serious inconsistency, indirectness, imprecision, mostly due to wide-ranging odds, a large heterogeneity. And these trials were not designed for just capturing the stroke risk, but including different kinds of population, women with cardiovascular risk. The receptor modulators were designed for osteoporotic women. As you can imagine, the combined meta-analysis showed very low certainty, very low evidence, and the two on hormone replacement therapy and receptor modulator moderate. If you put it on the forest plots as the pooled odds ratio for ischemic stroke in postmenopausal women treated with hormone replacement therapy versus non-Breyer, this is ranging, but it's nearly neutral. There's some, as you heard today, the World Health Study with an increasing odds of 1.36. On the other hand, the receptor modulators slightly decreased stroke risk. In summary, the pooled odds was 0.97, which is close to 1. Remember that the quality of evidence is very low. For the next question, it was the hemorrhagic stroke in postmenopausal women. Does hormonal replacement therapy compared to non-prior hormonal replacement therapy reduce the risk of hemorrhagic stroke in primary prevention? In postmenopausal women, we suggest against the use of hormone replacement therapy to reduce the risk of hemorrhagic stroke. Here we find a low quality of evidence and a strength of recommendation which was weak against intervention. For additional information, I show you the great evidence table for hemorrhagic stroke. These were combined 5 RCTs, which we could include in our analysis. For the inconsistency indirect, it was not serious, imprecision, wide-ranging odds. It was serious, and for all is publication bias strongly suspected because it was lower than 6 trials included in the analysis. A hemorrhagic stroke with the hormone replacement, it was 2, and receptor modulator is 3. Receptor modulator on osteoporotic women, remember that. If you do that in the forest plot, it's 2 trials that had the endpoint hemorrhagic stroke. Otherwise, it was combined ischemic and hemorrhagic stroke. And this was also an odds that was for the receptor modulator slightly decreased, but 0.75, close to 1 also. So with the low evidence, it was nearly neutral. We asked the question, how could it be with secondary prevention? How could it be with an outcome of those women after their stroke? Does estrogen, progesterone, others have an effect in postmenopausal women on functional outcome? Or how does it impact the mortality? And the same we did with hemorrhagic stroke. And here we had, in postmenopausal women, we suggest against the use of hormone replacement therapy to reduce mortality. I have to add, there were no trials examining the functional outcomes as we did the screening. And the strength of recommendation, it was weak against the intervention. Here the pooled odds ratio for fatal stroke mortality with a very low evidence showed in the West trial, and that's what Theodore also mentioned. It was close to 1 in the odds, so it didn't really change the mortality or the fatality. So the next big topic was help, she is pregnant. There are many uncertainties about how to treat pregnant women, and often it's the pregnancy that is prioritized. I say you have to prioritize the health of the women who are pregnant and see them as acute stroke patients. And this is a multidisciplinary decision, so you have to involve multiple specialties, either by telemedicine or those who are in place. We had asked, this is the second chapter, in pregnant women with acute ischemic stroke, does IVTs improve outcome as compared to no IVT? And you can imagine that you don't find any randomized controlled trials that included pregnant women. So we didn't have the available data to make a specific recommendation. But we added expert consensus statement in the Delphi vote. And this suggests that pregnant women with acute disabling ischemic stroke who otherwise meet the eligibility criteria can be treated with IVT after appropriately assessing the benefit risk profile on an individual basis. I say this is a multidisciplinary decision. We are strokologists, but we can help to treat those women. The only registry we found was the one also cited by Susanna this afternoon with Leffert et al. They included 40 cases that had a good outcome and good reperfusion rates and a slightly higher rate of intercerebral bleeding. We additionally identified all case reports and this one registry, and these are the case reports. And in the case reports, it's important to say that they all also mention the health of the baby and the delivery, which are also a very crucial point in treating this woman. So of the 33 cases included, 32, and now it's one in red and bold, you have to read the 32 of the 33 cases, 97% improved or had a good recovery. And the healthy baby was mentioned in 28 out of the 32 cases, nearly 90%, which is important. And abortion or medical terminated pregnancy, 4 out of 32 cases, 13% intracerebral hemorrhage, 3 out of 53 cases, 9% intrauterine bleeding, 1 case. The left side is the same for all. It's case reports and therefore low evidence, very low evidence in all of this studies. So the next chapter is mechanical thrombectomy during pregnancy. This is interesting because this is developing, increasing, and in pregnant women with acute ischemic stroke, does medical thrombectomy, intraarterial thrombolysis improve outcome as compared to no medical thrombectomy or intraarterial thrombolysis? We included also intraarterial thrombolysis because, as you can see, we are looking back the last 15 years and not just 4 years or 5 years after introduction of medical thrombectomy. And we have no specific recommendation to give because of the evidence was just case reports, not even registries. And we did that all members suggest that pregnant women with acute disabling ischemic stroke who otherwise meet the eligibility criteria can be treated with mechanical thrombectomy after appropriately assessing the benefit risk profile on an individual basis. And we added that in this woman with acute ischemic stroke to large vessel occlusion, if mechanical thrombectomy is available at that center, and mechanical thrombectomy alone should be preferred over IVT and bridging. If IVT just is available and not mechanical thrombectomy, IVT should not be withheld. A great evidence table for mechanical thrombectomy, intraarterial thrombolysis. We have 15 cases where it's just exclusively medical thrombectomy and the other ones combined. The 23 cases which showed an excellent recovery for the mother in 23 out of 23 cases, and a healthy baby in 18 out of 19 cases, so over 90%. Abortion, one of 19 cases, intercerebral bleeding, 2 out of 23 cases, so it was quite low, and no case of intrauterine bleeding. The IVT during postpartum, and now it's just case reports, so no great evidence table. In women with acute ischemic stroke during the postpartum period, does IVT improve outcome compared to no IVT? Few case reports, 5 that we identified, and those after 10 days after delivery, so not directly after the delivery in the first 3 days. There is no case published, and within 3 months. So in this period, all members suggest that postpartum women with disabling ischemic stroke occurring at least 10 days after delivery can be treated with IVT, with alteplase. The same, you have to assess the benefit risk profile of each patient. And mechanical thrombectomy during postpartum, 3 cases in women with acute ischemic stroke in the postpartum period. The period is defined as before, after 10 days and within 3 months after delivery. Suggests that all members suggest that postpartum women with disabling ischemic stroke occurring at least 10 days after delivery who otherwise meet the eligibility criteria can be treated with mechanical thrombectomy. And a majority of members suggested that if medical thrombectomy alone is available, it should be preferred over IVT and bridging therapy. So the last of our PICOs, the 2.5, was the menstruation. And this was very interesting, actually, with 6 cases in the NINST registry. And I was wondering, there are so many menstruating younger women, why are there just 6 cases? But it was available data that do not allow. Have we excluded them from all randomized clinical trials because they were menstruating? Never know. But this is an exclusion criteria too. And all members suggest that women with acute ischemic stroke during menstruation who otherwise meet eligibility criteria can be treated with IVT. Those 6 cases had an excellent outcome. To conclude, I say this is a neglected area of research. Looks like all patients for the menopause and the hormone replacement therapy were included in the 90s and 2000 with a dosage that was at that time modern, and they have changed, and the application mode has also changed. So we really need more RCTs on this, because in the future, postmenopausal women will also be treated with hormonal replacement therapy, and the risk profiles are changing. And we need more subgroup analysis of potential risk groups. And regarding the IVT and mechanical thrombectomy during pregnancy, postpartum menstruation, this is also obvious that we need more registries, and we need to include more women into registries for defining risk profiles and profiles for prevention for ischemic stroke and pregnancy postpartum. Summary conclusions: we find low to very low evidence in all recommendations. 5 expert consensus statements in IVT, mechanical thrombectomy, pregnancy, postpartum menstruation will hopefully help the clinicians to guide in everyday practice and care of these women, and maybe also be more proactive. And the guidelines highlight the need to identify evidence for stroke prevention, acute treatment in women in more vulnerable periods of their lifetime to generate reliable data for future guidelines. Thank you very much for your attention. I would like to thank everybody from the ESO, Julian Tork, Simona Sacco, the Guideline Committee, and Lucia Balma, Sabrina Mutter, and the others, Yvonne, from the headquarters. I would like to say we have a study that is the WISE study, and please, if you have women in pregnancy, postpartum, include them. You can mail us. Thank you very much.